Our next speaker is Ramesh SHAH. He is from Bombay, a innovator and a person who can make you a millionaire because he is wizard in financial investment in stock exchange. Welcome, Ramesh. And listen.
Thank you, Dr.
So
Boramani and
he's
Dr.
a
Sahu, to invite me for this keynote address. What I learned in last 5 years from our innovations, I believe in performance and not perceptions. I will divide my talk into these categories. In cataract, OmniGlow and Video Glow is the best choice for any microscope. It gives seamless red glow for the best depth of focus. Our video recording system with NASA grade camera is the best at an affordable cost. Cases of drop nucleus, corneal decompensation, all are reduced drastically, bad for the retinal surgeon. OmniGlow is the biggest gift in ophthalmic world all over the world. It saved 900 crores for ophthalmic world as we sold 4,000 OmniGlow across the country. We expect similar response from our Video Glow.
With OmniGlow, omnipresent, homogeneous and uniform and full red reflex with greatly enhanced stereopsis is 100% guaranteed in any position or any tilt of the eyeball.
You can see wonderfully the flow of the viscoelastic.
And they all have said that due to better glow and stereopsis, incidence of PC tear rent have decreased significantly, and by rare chance if it happens, the management of PCR and vitreous prolapse has improved a lot. And or IOL decentration induced by decentered capsular overlap. With OmniGlow, we can easily avoid all such late complications right at the time of surgery.
The second part of cataract is importance of Purkinje's image, especially for the multifocal lens. It helps you to locate rhexis perfectly. It helps in placing the IOL right at the center of the visual axis. Second part is eccentric rhexis in case of mature cataract. Refined blue staining has to be there for minimum 1 minute before you start the rhexis. It induces C3R changes on the capsule, especially the mature cataract, and this helps to avoid Argentinia's flag signs. This is the way you start in the eccentric thing and go all around. Third part of cataract is astigmatic keratotomy up to 2 diopters, which I think Dr. Boramani and Dr. Sahu has already told in SICS. From point, this is the nomogram which I used. You take the steep astigmatic keratotomy of 90% of the depth. This is the the blade which I use, calibrated blade, which is cash-based blade, which I purchased about 30 years back. We fix it at about 550 to 600. Make a one incision, one stroke, and then again go back so that you have a uniform 90% thickness of the astigmatic keratotomy. All the diopter corrections are done on the basis of IOL Master 700, Pentacam or Holiday cataract formula. Do not do AK in a pre-keratoconus or keratoconus cornea. AK reduces my toric implantation from 3 per day to 1 per week. Now coming to in cataract, the IOL selection which I have decided, which I have learned in last 3-4 years. Autofocus progressive polyfocal IOL. It has no diffractive rings, or a various EDOF IOL can reduce the quality of vision for near or distance and have relatively high rate of dysphotopsia. Autofocus Pro is my first choice of IOL. Polyfocal progressive lens, measurement of DOF is absolutely mandatory in all our IOL surgery. This is the largest lens in the world at present, 7.25 mm horizontal and 6.25 vertical. It eliminates the negative dysphotopsia because of its large lens. This is the depth of focus which is absolutely necessary in case you want to have a spectacle free happy patients. It occurs in 85% of the cases with Autofocus Pro. This is one example. Coming to the LASIK which I learned in last 5 years, 100 micron flap is better than 90 micron. 100 micron flap has lowest rate of epithelial fold. This is one concept which I feel is new, and it reduces the incidence of stromal folds. Customized aspheric ablation based on spherical aberration is a must. Ablation zone and transition zones are decided according to size of the pupil, photopic and scotopic. It reduces chances of negative dysphotopsia to near zero. A spherical aberration based ablation gives 6/4 vision in 85% of the cases. It also increases the depth of focus. Epithelial maculing pre and post LASIK for unhappy patients. Epi-LASIK is, I have started doing epi-LASIK in some of the keratoconus suspected patient with normal epithelium. LASIK, surface ablation, PRK or LASIK with the flap is far more superior than SMILE for quality of vision. At present, SMILE does not have customized or aspheric ablation. Only 8% of the patient with SMILE improves the vision by one line. Concentrate on customized spherical aberration profile ablation rather than going for making a various flap for the sake of money. This is the perfect aspheric ablation. If you see in the central portion, the ablation is more, then it is little less. So the first central portion, then it is about 60% in the periphery, and then rest of the thing is there. So it creates a very smooth ablation zones. Depending upon the size of the pupil, you can change these zones. Coming to the cornea, use of rho kinase, which we started with Dr. Kakadia. Molecule 27632 has for 3 months stored at less than 4 degree temperature as a local eye drops. 27 eyes are treated with that, and the corneal decompensation reverts without keratoplasty. In case of viral corneal infections, I remove epithelium with alcohol on the day 1. It reduces the viral load for the faster recovery without corneal opacity. A green light with rose bangle will be the future to treat the corneal infection.
Please notice the difference between corneal bandage lens and the Terrigo, the scleral bandage lens. Let us see the specifications of Terrigo lens. It is 21 mm in diameter. It is made of high water content hydrogel having 75% water content with highest possible oxygen transfer capacity. It is having peripheral soft skirt with slightly firm and more thick central optical zone, which provides a slight vaulting, keeping a potential tear film of approx 50 microns between lens and the cornea, and it can be kept in eye for 24/7 for 4 months at a stretch.
Without removing the contact.
Terrigo lens is also very much useful in almost 15 other indications.
Now, uses of Terrigo, 7 eyes, which what I am telling you the statistic which I have used it. 7 eyes with irregular cornea including keratoconus and post-RK. 2 of them are for recurrent erosions. Adenovirus infections, which we removed the epithelium and put the Terrigo lens. Herpes lesion also we have used the Terrigo lens. 2 cases of bullous keratopathy with painless eye for last 3 months. Maximum duration with constant Terrigo was for not 8 months. It is not 10 months, it is 8 months. One patient could not tolerate, so we removed the contact lens. This is one patient which has come from Saudi. He's gone very bad care, RK done. His vision improved from 636 to 612, and he has put this lens for 4 months before.
Its material has very high affinity for moxifloxacin, so it is a drug delivery lens which it absorbs very fast and retains long and well, and slowly releases moxie over many hours, so putting moxie eye drops twice a day is enough. Thus, understand it as not only a bandage lens but as a sort of a medicated bandage lens.
This is one patient which we could see the moxie glow on the side of the contact lens, the edge of the contact lens. Coming to the glaucoma, TUG means treatment of ultrasound for glaucoma, for open and pseudophakic glaucoma. It's an ultrasound treatment for clean trabecular meshwork. OmniFlow is the second part of it. With uncontrolled glaucoma, it's a retrobulbar or suprachoroidal drainage device. It is the first device in the world to drain the aqueous relative empty space of retrobulbar space. OmniFlow should be a primary choice for at present we are doing for the congenital glaucoma.
While giving 30 watt energy at phaco tip, we are unknowingly also giving 3 watt energy to opposite one quadrant of trabecular meshwork.
This is under the process of
So we
FDA
thought
approval.
that if ab
Probably end
internal
of this year, we
ultrasound in
might get the
OT
Indian FDA
can
approval.
lower intraocular pressure, can we achieve it by non-invasive ab externo approach in OPD or as an office procedure? Traboclean is as good as cleaning a blocked tea strainer. OmniFlow is a unique, novel, small and the best glaucoma drainage device which is a shooterless short shunt
One from UK
to drain aqueous
got
humor
a similar
from
principle
anterior
and
chamber
got
to the retrobulbar space.
PC marking recently last year.
With OmniFlow, the IOP is down from 60 to 80 to 10 to 12 as soon as the tube is in. The microvalve regulates the IOP, keeping always above 10 millimeters of mercury. It gives excellent results in all severe, intractable, bloody and oily open-angle glaucomas. It is a quick 10 to 12 minutes, almost sutureless surgery. OmniFlow Supra is another version of OmniFlow. OmniFlow Supra is a suprachoroidal tube shunt for BAGS, BAGS, that is bleb-free ab externo glaucoma surgery. It drains the aqueous humor from anterior chamber to suprachoroidal space.
Third one is a keratoconus. Epithelial mapping is a very important thing. If it is not thinning over the cone, that means the keratoconus is not existing. Epithelial mapping does not follow the same pattern after the age of 45. Comparison of epithelial mapping pre and post C3R will help us the effectivity of the treatment, and green source of light with rose bengal will be a great tool for keratoconus in future. We have already done about 10 cases of keratoconus with brilliant results and K flattening up to 5 to 6 diopters. This is one thing you can see, the epithelial mapping which is thinning over the cone, same place. This is the one where we have treated with keratoconus, the C3R. From thinning it is gradually becoming the same one, the means uniform over the cone. Moxiglow is another one with the UV light, since the time is not there. So conclusion is always stay ahead of the technology. 6x4 vision is possible in 80% of the case, 80-85% of this spherical base, flap base LASIK surgery. 6x4 vision is very rare in smile. Spectacle free for all the distance without dysphotopsia is possible with varifocal 7.5mm autofocus pro. Newer modality will be reality in glaucoma treatment, including like TUG and OmniFlow. Monofocal IOL must be replaced, that's what I feel, with a ringless, any ringless, varifocal or other one. Bifocal spectacle are normal, at present are replaced with the varifocal glasses. Almost everybody wears varifocal glasses. Treat the patient with the patient's need, not their pocket. Always believe in performance, not perceptions. Earn for yourself and not for the companies. Our future innovation is phaco-like machine which you are going to create in 1/10 of the cost for SICS surgeon is almost done. Autofocus video system which we have created will be less than 1 lakh rupees for the quality of other system which is around 20 lakhs. Casbier astigmatism knife, we are going to make it, at present is available at 3 lakhs. We are trying to bring down to 25 to 30,000 rupees. And green light at present C3R machine which is about 24 lakhs, we might bring down to 1.5 lakh rupees. An affordable TUG machine which is 24 lakh, 34 lakhs now, we might bring down to 10,000 rupees. With this, thank you so much all of you.
Yeah, thank you Dr. RC for